So, a very good morning on a Monday. As you can see on the screen, our professor and HOD is there with another gentleman who is a Nobel laureate, and he shared the Nobel Prize with somebody else for discovery of the AIDS and HIV. AIDS is discovered first and then HIV. So now, let us go and see about the discoverers of the HIV/AIDS complex. Luc Antoine Montagnier, French virologist, born on 18th August 1932. And again, Robert Gallo is an American biomedical researcher, born on 23rd March 1937 in America. These are the people who have given the knowledge about HIV virus and the related AIDS. First, it is not the virus that is detected, it is the syndrome that is detected. So, discovery of AIDS in New York and Los Angeles, somewhere in 1981. There was an unexplained outbreak of corpus sarcoma and PCP, pneumocystis caridine pneumonia. But subsequently it is changed as pneumocystis jirovecii pneumonia in adults. So then they have made a research as to why the sudden increase of cases. And it is found out that there was a loss of immune competence and susceptibility to relatively virulent organisms, like say Candida, which are on the skin. And also a higher turnout of malignancies, lymphoid malignancies and other malignancies. So this syndrome, they have named it as acquired immunodeficiency syndrome. What is acquired? Acquired immunity against natural immunity. Likewise, there is some primary immunodeficiency, and this is secondary immunodeficiency, and this is acquired. So the name acquired immunodeficiency. So subsequently, they have tried for the organism, and they found out the presence of a viral particle. So, point is here, AIDS is discovered in 81 and 1983. The causative agent of AIDS, that is HIV, was discovered by Luc Montagnier, French virologist, and then who called it as a lymphadenopathy-associated virus, and Robert Gallo in 84 in USA, independently. He called it something as HTLV, that is human T-cell lymphotropic virus. So, both are talking about the same thing, Robert Gallo and Luc Montagnier earlier. So, there was a committee, International Committee on Virus Nomenclature, in 1986, named this particular virus as HIV, human immunodeficiency virus. So, Namakaranam anedi appu jarigindi HIV. And ELISA became available. You know ELISA, enzyme linked immunosorbent acid, available for anti-HIV antibodies in the serum in 1995. And today they have HIV-1 and HIV-2 subtypes. Now, coming to taxonomy, so I always call it a tax on me, that is taxonomy. They belong to a family called Retroviridae. There's an interesting story why it is called Retroviridae. Subfamily Lentiviridae and genus Lentivirus. Why it is called Retroviridae? So reverse transcriptase or RT is the characteristic enzyme of this family. Then why it is called Retroviridae? Usually, it is from the DNA an RNA copy is made and protein synthesis is done. But here, it is in the reverse. That's why it is named as reverse transcriptase. So from RNA to a single-stranded DNA, and that single-stranded DNA becomes a double-stranded DNA. And then the manufacture of viral proteins and all those things appear. So, this is called reverse transcriptase. Actually, under Lentiviridae or lentivirus group, what are all the various other agents? In primates, human immunodeficiency virus, HIV type 1 and 2. Simian, that is related to monkeys. Simian immunodeficiency virus, causing SAIDS, S-A-I-D-S. Sooty Mangabe monkeys, so SIV, SM. From rhesus macaque, closely related to HIV type 2. And again, another one isolated from chimpanzee, closely related to HIV type 1. So the point is, the things are the HIV virus that are isolated from chimpanzee are close to HIV type 1, and from the Mangabe monkeys close to HIV type 2. And in non-primates, feline T lymphocyte tropic virus, FTLV, causing feline AIDS. So these are all the various other possibilities that can occur. Now, what about the general description? It's a spherical enveloped virus, 90 to 120 nanometers in size. And there is a nucleocapsid which has an outer icocytic shell and inner cone-shaped core, enclosing the ribonuclear proteins. Okay, all of this is from your standard textbook. So these things you have to remember. But I'll tell you some comparison for the remembrance of the figure which you are supposed to draw. We said something about the envelope. Manalu, ఏదైనా hotel room లోనో లేకపోతే చుట్టాల ఇంట్లోనో ఉండి వచ్చేసేటప్పుడు దొంగతనంగా వాళ్ళ దుప్పటో ఏదో ఒకటి పట్టుకొచ్చిస్తారు. అలాగే వైరస్ పార్టికల్స్ కూడా ఒక హోస్ట్ సెల్లో నుంచి బయటకు వచ్చేటప్పుడు దాని తాలూకు ముసుగు కప్పేసుకుని వస్తాయి. సో host cell component, it is a lipid derived from the host cell, and virus component is the membrane glycoprotein. So both together, it's called a lipoprotein. And just like your present world pandemic, COVID-19, the virus SARS-CoV-2, this also has spikes. And GP, glycoprotein 120, is on the surface. And transmembrane pedicles, GP41, glycoprotein 41, which anchor the transmembrane, they are called the transmembrane pedicles. So this 120 is anchored onto the virus by GP41. And spikes are the main components of the virus. And CD4 receptors, they bind along with co-receptors, and co-receptors CXCR4 and CCR5 on the host cell. So now this is what the diagram which you have to remember lifelong. ఎవరైనా ఒక ఆవిడ కుప్పులో పువ్వులో పెట్టుకుని ముక్కుకి ముక్కెలు పెట్టుకుని 2 చెవులకి 2 చెవి దుద్దులు కర్ణాభరణాలు పెట్టుకుంటే, అలాగే ఆ కొప్పు నిలవడానికి ఒక బన్ ఉంటుంది. ఆవిడ దాని మీద పువ్వులు పెట్టుకుంది. ఇలా గుర్తుపెట్టుకుంటే మీకు ఈ బొమ్మ వేయడం ఈజీ. మోస్ట్ ఇంపార్టెంట్ పాయింట్ ఏంటి? ఎన్వలప్ గ్లైకోప్రోటీన్ స్పైక్ GP120, అది పూలదండ అనుకోండి. ఆ తర్వాత ఎన్వలప్ అంటే ఒక బన్ను, ఆ కొప్పు కావాల్సిన బన్ను. మరి అక్కడ కొన్ని హెయిర్ పిన్స్ ఉండాలి. ఆ బన్ను ఈ జుట్టు అన్ని కలిపి ఉంచడానికి. ఆ హెయిర్ పిన్ ట్రాన్స్మెంబ్రేన్ పెడికిల్ GP41 అనుకోండి. సో 120, 41 వచ్చేది. ఒక ఎన్వలప్ వచ్చింది. మరి ముక్కుకు పెట్టుకున్నాం, ముక్కు పుడకలు 2 అటు ఇటు, అవి రివర్స్ ట్రాన్స్క్రిప్టేజ్ ఎంజైమ్ అనుకోండి. 2 సింగిల్ స్ట్రాండ్ RNAలు ఉన్నాయి. అవి కర్ణాభరణాలు. కర్ణాభరణాలు అని ఎందుకన్నాను? RNA కర్ణ, అందుకని అలా గుర్తుపెట్టుకుంటే RNA 2 చెవులకి 2 దుద్దులు అనుకున్నాం. తర్వాత outer shell of nucleocapsid P18, inner nucleocapsid P24. ఇది కూడా గుర్తుపెట్టుకోవాలి. ఎందుకని? P24 యాంటీజెనిక్ డయాగ్నోస్టిక్ గా మనకి పనికొస్తుంది. అలాగే యాంటీబాడీస్ టు GP120 డయాగ్నోసిస్ కి పనికొస్తాయి. మిగతావి అంతగా రాదు. ఓకే, సో మోస్ట్ ఇంపార్టెంట్ figure which will never leave you. Be happy, it is only the figure, not a virus. Okay, so this figure you must be able to draw a number of times and reproduce in the examination problem. So it should represent the envelope glycoprotein spike GP120, and again the envelope, and then transmembrane pedicle, and then the outer shell P18, and also the nucleocapsid P24, and then single RNA 2 strands, and also reverse transcriptase. So this is the figure, and the comparison I gave you, it is only for comparison's sake. Okay, just remember the face of a well decorated bride. You can remember this figure easily. Okay, the comparison ends there. Major antigens of HIV. So now we have seen envelope, shell, core, and polymerase. Envelope lo spike antigen GP120, that is the principal envelope antigen. Transmembrane pedicle GP41, and then shell antigen nucleocapsid protein, that is P18, and core antigens, that is the core of the particle. Principal core antigen is P24, that is most important. Other antigens, other core antigens are P15 and P55, and you have seen the polymerase antigens. Okay, 2 dots, P31, P51, P66. Now you can see a 3D view, like the spikes and the transmembrane pedicle, and also a shell, and then the inside you have double-stranded 2 single-stranded RNA with coat and an inner coat. Okay, so this is a 3D view of the virus. It is only for understanding it is shown. Or maybe I cannot draw it, such a blue diagram. It is only for understanding. Now, coming to the genome. Okay, you have seen P120, GP120, GP41, all this. What is the genetic representation? So two identical single-stranded RNA and they are positive sense. So whenever you describe a genome, you should say whether it is DNA or RNA, whether it is single-stranded or double-stranded, or whether it is positive sense or negative sense. So here, two single-stranded RNA with positive sense. And also with the enzyme reverse transcriptase. Why it is called reverse, we already discussed. It is first DNA to RNA, but here first RNA నుంచి DNA వస్తుంది. Okay, single stranded RNA నుంచి single stranded DNA, తర్వాత single stranded నుంచి double stranded DNA వస్తుంది. So that double stranded DNA is called a provirus. And that gets integrated into the host cell chromosome. ఇంటి దొంగని ఈశ్వరుడైనా పట్టలేదు అని సాగుతాం. అలాగా ఇంట్లో చేరిపోతుంది ఒక మెంబర్. సో ఇంట్లో ఎలా అయితే ఒక దొంగ చేరితే పట్టుకోలేమో ఇంటి దొంగని, this HIV virus gets integrated into the host cell chromosome. And for a long period, maybe 10 years, it will keep quiet. And then synthesis of viral RNA and other components will be going on silently. Now, so viral genes and antigens. So which viral gene is responsible for what antigen? That's what we are going to see. So three structural genes, GAG, POL, and N, and also a variety of non-structural and regulatory genes out there. Let us see. GAG, POL, and N. When you talk about genes, it is the italicized version, 20%. So you have seen that they are represented with italics, okay? GAG in italics. So GAG gene, it determines the core and shell expressed as P55 precursor protein, cleaved into P15, P18, and P24, out of which we are worried about P24 only. Because P24 antigenemia, you can estimate the viral load because of this P24 antigen. So GAG gene is important. They make up viral core and shell, and major core antigen is P24. Clinically, why it is important? Early detection. Even before antibodies appear, the P24 antigen has can be done. And moreover, first, ఒకసారి appear అయింది, మళ్ళీ disappear అయింది, మళ్ళీ appear అయిందంటే ఏంటి? It's an exacerbation of same infection. Coming to ENV gene. So this is the envelope, as you can guess, ENV envelope gene. This is GB150, and it is separated or it is cleaved into GB120 and GB41. We said about the surface spikes, and they are your GB120. And GB141 is the transmembrane anchoring pedicle. Hairpin in Japan, and a pool Garaka 120 anukunte, hairpins 41 GB41. Clinical importance, antibodies to GB120 are detectable till the late or terminal stage. So the antibodies to GB120 are detectable even in the late stage. Okay, so that is why it is. Coming to POL gene, again you can guess POL is polymerase. POL gene codes for reverse transcriptase RT enzyme and other viral enzymes like proteases or endonucleases, P31, 51, and P66. There are not much diagnostic or prognostic importance. Then why the hell they are maintained? Just because you have to know. Okay? So the reverse transcriptase enzyme is coded by POL gene, and P31, 51, or P66. They are not much of a prognostic or diagnostic value. Okay, so even if you estimate, and most of the enzyme instruments or most of the GP estimates are very costly. So, better you estimate about GP 140 if you want to know, or the P24 antigen and the viral load. Okay. Now, we have talked about structural genes, and these are the non-structural regulatory genes. Again, the names are 3 letters and they should be in italics. So, talk about TAT. TAT is trans-activating gene. It enhances the expression of all viral genes. Another is NEF, negative factor gene. This is very important. Alavigani chota adikula manarad. So, virus also is well known for its behavior. So, genetically, it should have a control when to become less and when to become more aggressive. Okay? So, negative factor gene, it down-regulates the viral replication. And REV, this is an enhancer, regulation of viral gene. REV, it enhances the expression of structural. So, NEF and REV are in their action, they oppose each other. So, NEF is a negative or down-regulating viral replication, whereas REV, it enhances the expression of structural proteins. Coming to VIF, this is viral infectivity factor gene. So, whether a given strain of a virus, whether it is highly infective or not that infective, depends upon the VIF. Now, we said there is a HIV-1 and there is a HIV-2. So, specifically, if you do the VPU or VPX, you will be able to know whether it is HIV-1 or HIV-2. Why should you do? Again, for the epidemiologists in that area, HIV-1 or HIV-2. So, genetically, if you see VPU, it is HIV-1. VPX, it is HIV-2. How to remember? X lo ilaga rendu unnai. X letter lo elagithe rendu geetalu untayo adi rendu unnai kabatti HIV-2 ani gurtupeట్టుకోండి. Automatic ga migilindi HIV-1 e kada. VPU is HIV-1 and VPX is HIV-2. And then VPR, it stimulates the promoter region of the virus. Promoter region of the virus. So, this is also having a regulatory effect on the positive aspects of the genetic viral component. And LTR, that is a long terminal repeat sequences. Okay, so now there is a diagrammatic representation. This is shown only as a completion. At least I cannot draw the whole thing. Okay, so major things you should remember is on both ends you have a long terminal repeat sequences, that is 5N and 3N, that is LTR. And you have the gag, ball, and envelope genes. It is the structural. And coming to non-structural, the other representations of the P724, PCAM, P66, P51, 32, or 120, 41. These are all the other genetic representations. This is a compact figure. This, anyway, it's not for trying for representation. It is only to show you the arrangement, both structural and non-structural genes. Okay. HIV is HMV. I know code bit. HIV and human immunodeficiency virus, all of us know. But HIV is what is voice and అది బాగా హెచ్ఎంబి రికార్డులు ఇలాంటివి పాపులర్గా ఉండేటప్పుడు హెచ్ఎంబి ఆ హెచ్ఎంబీలో ఉండే కుక్క మగదా ఆడదా అని ఒక డిస్కషన్ కూడా ఉండేది. ఇంగ్లీష్ గ్రామర్ ప్రకారం ఇజ్ అన్నారు కుక్క మగది. సో పాయింట్ ఈస్ హియర్ హెచ్ఎంబీ హైలీ మ్యూటబుల్ వైరస్, ఎన్ని రకాల మ్యూటేషన్స్ రావచ్చు. Why this mutability? It can be nucleotide sequences or cell tropism. You can see that the system or the virus have its various systems. So it may be specially inclined to gastrointestinal system or specially inclined to nervous system, like that. Growth characteristics. A particular virus strain has increased growth characteristics and certain things, not much of replication. And cytopathology wise also, CPE, cytopathogenic effect. And the isolates may exhibit different characters from different people. Okay, that is understandable. A strain isolated from A may not resemble totally the strain isolated from B or C or D. That is understandable to some extent. But in the same patient, at different times of the day, if you isolate, again there is variation. That is why when such a highly mutable virus is there, it is very difficult to prepare a vaccine. Okay? That is why you are unable to have vaccine. But why so much of antigenic variation? ఏదో గమ్మున ఒక మోడల్ ఉంటే దాని ప్రకారం ఎదుర్కోవచ్చు కదా, మనకి ఎంత కష్టం నువ్వు కలెక్ట్ చేయడం అంటే ఇక్కడ ఉన్న ఎంజైమే అలాంటిది. రివర్స్ ట్రాన్స్క్రిప్టేజ్ అనే ఎంజైమ్. దిస్ ప్రాసెస్ ఆఫ్ రివర్స్ ట్రాన్స్క్రిప్షన్ ఈజ్ ప్రోన్ టు లాట్ ఆఫ్ ఎర్రర్స్. అందువల్ల you have high antigenic variation and diversity of HIV. And God or whoever has prepared, made us, made the HIV virus also. So he has or she has given inbuilt protections like mutation to HIV virus also. And our endeavor will always be to somehow create a virus which is not harmful to us or kill the virus by any means. Okay? So now, error-prone nature of reverse transcription and the reverse transcriptase activity, they are important for the antigenic variation and diagnostic. And as I said, we have HIV-1 and HIV-2 based on molecular and antigenic differences. One is the prevalent all over the world, and two, only 40% genetic identity with HIV-1, more closely related to simian ID virus, simian immunodeficiency virus. And as can be expected, this is not as well as HIV-1, largely confined to West Africa. But presently the travel is very fast and very wide. Like we are well connected, like the networks say. So we are connected with all over the world, and so it need not be West Africa confined as people do travel. Coming to HIV-1, there are subtypes of HIV, A, B, C, D, and E. And this again, for you to remember, is only for completion's sake. Why each particular subtype and the determination is done? Again, for epidemiological purposes. HIV-1 strains have been classified at least into 10 types. Okay. So, please remember that in West Africa, they do not fall within the group M, that is major. What is this major? All the subtypes constitute a group of major which causes most HIV-1 infections in the world. That's called as group M. And a few of those strains which do not fall into group M, they are called group O. They are outliers, O. And some later isolates of HIV-1 from Cameroon. Cameroon అనేది ఒక తీర్థయాత్ర స్థలం లాంటిది. మీకు ఏ హెచ్ఐవి మోడల్ కావాలంటే హెచ్ఐవి మోడల్ దొరుకుతుంది. So please remember, never go to that such a place. Or even if you go, be very careful. Distinct from the M and O, and that group is called M. That is no. So HIV-1 లో 15 subtypes ఉన్నాయి. Majority of the things they fall in M group, and some are isolated which do not fall into the group M. They are called O group outliers, and some isolates from Cameroon. They are called the new group M. And what about the transmissibility? Again, C and E, most common in Asia and Africa, are readily transmissible even by, mainly by heterosexual contact, that is male and female. And that subtype B, that is the American strain. And one word about the gay marriages which are accepted even in India. So be careful. It is the mucosal damage that transmits the virus. And subtype B, American strain, preferably injection or homosexual. Intravenous drug abusers and homosexual contact. These are the important features in American strain. We said something about growth characteristics. HIV-1 isolates from asymptomatic carriers. That is, people who launch the virus, but they don't have symptoms, clinical latency. They grow slowly. And strains isolated from symptomatic AIDS patients, they grow faster. So that is why the clinical picture is very fast. Okay. And asymptomatic carriers, they grow slowly. The course of infection is decided by whether it is the asymptomatic carriers or in the AIDS patients. Coming to resistance of the virus. Thermolabile, that is sensitivity to heat, 10 minutes at 60 degrees or 10 seconds at 100 degrees. So, that is the temperature variation. At 60 degrees, it takes 10 minutes, 100 degrees to 10 seconds, it can tolerate. And it survives in dried blood. That is why there is a blood spot, red spot assay also can be done. And 7 days, it can be there at room temperature. And lyophilization, that is freeze drying in vacuum, it can survive. So these are the important things. And autopsy, isolated from various tissues. So that is why, even after death, if you want to diagnose, you can do it. Okay? Up to 16 days, they are isolated from the dead body. So these are the things that you have to know. Coming to inactivation, okay, 68 degrees centigrade for 72 hours, they are totally inactivated. Liquid plasma, 60 degrees centigrade for 10 hours. And the household disinfectants which you use, 50% alcohol, 10 minutes. So within 10 minutes, they are inactivated. If you use 50% ethanol or 35% isopropanol, 0.5% Lysol, the routine disinfectant we use in the hospitals, and hydrogen peroxide, 0.3%, 10% household bleach, 2% glutaraldehyde. Why glutaraldehyde? For the scopes, gastroscope, endoscope, all these things, the scopes are cleaned by glutaraldehyde, right? Glutaraldehyde. And extremes of pH, 1 and 30. So, it can be inactivated with such disinfectants. Standard recommendation is hypochlorite, 5 grams per liter, that is 5000 ppm. ppm is parts per million available. For all medical instrumentation, 2% neutron air. For surface decontamination, 10% of household bleach, lab use, hypochlorite solution. Clotted or unclotted blood with HIV, either in a needle or a syringe, undiluted bleach for at least 30 seconds. Coming to pathogenicity. Inter alia, we have been discussing about the CD4 T lymphocytes, how they are developed and all that. So now CD4 plus T lymphocytes, they are the helpers. And CD4 minus 8 are the other lymphocytes which we don't want to have. Okay, so CD4 count is important. If the CD4 count is good, the person's health is good, and it is a prognostic value also. Suppose when you are starting treatment, if it is say 400 or 500 and it is improved say to 600, 700, you know that the drugs are working. Okay, so CD4 T lymphocytes, B lymphocytes, monocytes, macrophages, all are susceptible, and the specific binding is by the CD4 receptor is to the viral component, that is GP120, and cell fusion. The confusion starts with the cell fusion. So that is mediated by GP40. And what are the co-receptors? We just saw CXCR4 and CCR5. Again, CXCR4 for T cell tropic HIV strains and CCR5 for macrophage tropic strains. What is the primary mechanism? So CD4 plus T lymphocytes are there. They are the helper or inducer cells. And low CD4 count becomes with progression of the disease. And even reversal of T4 to T8 ratio, just like your AG ratio, albumin and globulin, in health and in disease. Here also, T4 T8 ratio, the deficiency of CM and cell membrane immunity, it can reverse. So infected T4 cells do not release normal amounts of IL-2, gamma interferon, and other lymphocytes. So that is the pathogenicity induced by HIV. So what is the main reason? The infected T4 cells unable to release the normal amounts of interleukin-2, gamma interferon, and other lymphocytes. The important feature of HIV infection is polyclonal activation. If polyclonal activation అంటే IgG నా M A నా D నా A నా దానికి సంబంధం లేదు. ఒక మామిడి చెట్టు ఉంది, దానికి మామిడికాయలు ఉన్నాయి. సరిగ్గా గురి చూసి కొట్టగలిగితే ఒక రాయి వేస్తే చాలు. కానీ ఒక 10 రాళ్ళు 20 రాళ్ళు 100 రాళ్ళు తీసేసాం అనుకున్నాం ఒకటేసారి. ఒకటే రాయి తగిలించింది తాగకపోవచ్చు కూడా. So this polyclonal activation also does the same thing to the immunological system. So hyper gamma globulinemia results. To antibody production. Okay, so that is how AMI is gone. So monocyte macrophage function also is affected. See, reticular endothelial system is monocyte macrophage. So CD4 receptors, as we said, what are all the susceptible cells? B lymphocytes 5 to 10%, monocytes 10 to 20%, and macrophages. If they are in the lungs, you call them as alveolar macrophages, and if they are in the skin, you call them as the Langerhans cells, and glial and microglial in the CNS. So these CD4 cells are important in the involvement of the B lymphocytes, monocytes, macrophages of various systems. But without involvement of CD4, the tonsillar follicular dendritic cells, they can be infected without the involvement of CD4. See, that much of spread is possible for the HIV. Role of CXCR4 and CCR5. So envelope GP120, it is specific binding for the CD4. It's by GP120, and GP41 causes the cell fusion. And binding to CD4 requires the participation of co-receptors. Co-receptors are CXCR4 for the T cell tropic HIV strains and CCR5 for macrophage tropic HIV. This co-receptors can be a 2 marks question. So co-receptors of HIV. So please give special importance while you read to this CXCR4 and CCR5. And general virology, you remember the code APU-BMR, that is adsorption, and then penetration, AP, and then U, uncoating, B, biosynthesis, M, maturation, and release. All these stages are seen in the HIV also. So viral reverse transcriptase mediates the transcription of RNA into double-stranded DNA. So single-stranded RNA, from that single-stranded DNA, and from that double-stranded DNA. And this is, as we told already, integrated into the host cell genome, and then it takes a long time. Latency is for a long time. That is why there are certain phases where the person is asymptomatic, clinical latency, but virologically the replication is going on. So be very careful. These are the various things possible because of the viral replication. Why there is long incubation period? We said it is because of the integration into the genome. The HIV virus genome into the host cell chromosome. Virus can be isolated from. Why you should know? That is, these are all the specimens. These are all the specimens. And also, you can easily imagine what are the various difficulties if there is a delivery by HIV positive woman. Suddenly, the amniotic fluid and all splash all over the body by going to the conjunctiva. So blood, lymphocytes, cell-free plasma, semen, cervical secretions, saliva, tears, urine, breast milk. So almost all the body fluids are there. So during infection, what is going on? The CD4 T lymphocyte count is going down, and T8, that is the suppressor cells, that ratio, that count is going up, and there may be a T4 T8 reversal, and there is a suppression of CMI, cell-based immunity, and suppression of EMI also. And we told that polyclonal activation is there, especially hypergammaglobulinemia in adults. IgG and IgA are elevated. Infants and children, IgM also is elevated. And sort of type 3 hypersensitivity, that is disastrous reaction or serum sickness, allergic immune responses can be there. And moreover, if you challenge the body's immunological system with the new antigens, there is poor response. Monocyte-macrophage function is damaged. Lack of activation from T4. As we said earlier, the interleukin, interferon, they're all secreted by the activated T4. And here, the T4 count is becoming less. And monocyte-macrophage function is also less. And that is why you don't have proper chemotaxis, antigen presentation, and intracellular killing of the organisms. You have learned about oxygen burst theory and all. So, defective intracellular killing. And even the natural killer cells and cytotoxic T cell activity is diminished. So to say, it is immunity depressed. Okay? So it is something like a person losing the muscles, losing the liver, losing the various controls. So he cannot run or he cannot climb up. All his defenses are at a low level. So likewise, most of the cells and their responses are subdued because of the pathogenesis involved by HIV. So what are all the immunological abnormalities if you want to see? Characteristic of AIDS, lymphopenia, that is the lymphocytes are less in number. Selective T cell deficiency, that is CD4 helper cells are reduced, and inversion of T4 T8 ratio, and decreased or delayed hypersensitivity and skin testing. Okay, you do a Mand, so it is hypersensitivity testing and skin is delayed. Hypergamma-globulin, which are referred to like IgG and IgA in adults and in children. Polyclonal activation, that is useless antibodies are produced in great amounts. And decreased in vitro lymphocyte proliferative response, so mitogens and antigens, phytohemogglutinians and all that we have seen. So decreased response and decreased cytotoxic response by T cells and NK cells, antibody response to new antigens, monocyte-macrophage system, elevated levels of immune complexes in the serum. This is what we have been telling about the type 3 type of hypersensitivity reaction. But why the clinical picture is so? Not due primarily to viral cytopathology. HIV virus chedo chesesindani bhapadathu. It is our immune system, the failure of the immune response by the system, secondary to the HIV invasion. Okay? That is the crux of the issue. Patient is susceptible to opportunistic infections and also cancers. Remember now, in the first slide we said AIDS was discovered first and then only the virus. Okay? So that is how you have seen some increased number of cases of corpuscle sarcoma and your PCP pneumonia. And then I thought, like, why this thing is going on? And then they have chanced upon the discovery of the virus. Subsequently, they knew the constitutive organism. So, rise in corpuscle sarcoma cases, and also dementia and other neurological disorders due to viral effects on CNS. So, this is a repetition. Okay, this is what we have to see. Now, acquired immunodeficiency syndrome, AIDS. We are all clinical microbiologists, okay? Everything I have to correlate clinically. So, a 35-year-old commercial sex worker, please don't call a female or a male, because sex is now recognized as a profession in some other countries, and the government provides for all the problems associated with accepting using his or her own body as a passive or active agent in the sex activity. So don't call a prostitute or a gigolo. You should call them as commercial sex workers. Presented to the medical OPD, the history of weight loss, decreased appetite, cough with expectoration for a duration of 1 month. Total WBC count was low. AFB shows positivity for acid-fast bacilli, grade 2. And HIV serology was reactive with the 3-test strategy of National AIDS Control Organization, that is NACO, which is know in the next class. And CD4 count was 350 cells. And the patient was referred to the ART center for antiretroviral and anti-tubercular chemotherapy. She was advised to return for a follow-up after 2 weeks and use a condom during sexual contact. So you need not be a clinician. With an MD general medicine degree in MD microbiology, if you see the report, you advise properly. Use condom because you will not be able to spread to others. Condom or a female femidome. Okay? So this is the importance of knowing the clinical scenario. So coming to the various classifications that are available. Classification system for HIV infection from CDC USA. Center for Disease Control and also Prevention. Group 1, Group 2, Group 3, Group 4, and again in Group 4 we have group subgroup A, B, C, and C1, again C2, D, and the E subgroups are there. Okay? So, AIDS is so-called last stage. AIDS is only the last stage in the wide spectrum of clinical manifestations in HIV infection. And stage-wise, what is shown in the tabular column here, we are giving acute HIV infection group 1. It is called a seroconversion illness, and acute retroviral syndrome can be there. So first 3 to 6 weeks infection, 50% of the persons have fever, headache, and rashes. Seroconversion, that's where HIV antibodies are usually negative at the onset, but they become positive during the course. But clinical illness may not be there. If somebody has acute retroviral syndrome, fever, fatigue, rash, pericarditis, and P24 antigenemia. So you can estimate the P24, and that is the valid code. So it may be there. The first stage is group 1. Coming to group 2, I think we are running short of time. So to summarize, we have seen about the morphology of HIV virus, and which is discovered first, that is AIDS, and then HIV virus. And we have seen the pictorial or diagrammatic representation of HIV virus, and also the genes responsible, that is structural and non-structural genes. And now we are discussing about the AIDS, that is the clinical manifestations, group 1, group 2, group 3, group 4. In the group 4, we have some subgroups. So tomorrow again, we'll sit with the next class about HIV. Okay? Thanks for listening. And tomorrow, we'll meet again.